From the Heart.org Medscape Cardiology, this is the Bob Harrington Show. Dr. Robert Harrington is the Arthur L. Bloomfield Professor and Chair of Medicine at Stanford University.
Hi, this is Bob Harrington from Stanford University on the Heart.org and Medscape Cardiology. For a number of years now, I've had the privilege of talking with my close friend and colleague, Michael Gibson, around this time to sort of summarize the year in cardiology. A lot of times it's to talk about trials. Sometimes we try to bring in some policy issues or other things that seem to be resonating with our colleagues across the world of cardiovascular medicine. This has obviously in 2020 been a really difficult year for all of us. And first, on my behalf, I want to thank all of our frontline clinical workers out there. I know that this has been an extraordinary year. I also want to thank our researchers who have kept things going throughout a very difficult year. And that's going to be the topic of today. Mike and I are going to focus in this segment on all of the happenings in cardiovascular medicine that we found interesting outside of the COVID setting. We're going to do a second show on the COVID-related issues, but this one we're going to stick to non-COVID issues. We're going to talk about lipids. We're going to talk about antithrombotic therapy, some new findings in heart failure, and maybe even wrap that around some of the lessons learned about doing research this past year that maybe we learned from COVID. So with that, let me introduce my close friend and colleague, Dr. Mike Gibson. Mike is a professor of medicine at Harvard Medical School. He's an interventional cardiologist at the BI Deaconess in Boston. He's also the CEO director of the BAME Institute, an academic research organization. Mike, thanks for joining us here on Medscape Cardiology.
I can't believe you keep having me back. How many years have we been doing this?
It's a lot. I'm going to guess it's at least 5 or 6 now, maybe even longer. It's really, to me, one of the highlights of the year is to hear what you think and have some good conversation about the things we both learned over the years.
Yeah, same here.
Mike, let's dive right into it. Let's go for some interesting findings in the lipids world this year. And in particular, I want to bring up 2 topics, one of which is omega-3s. And then the second will be, do statins cause muscle pain? So let's jump into it. The lipid omega-3 story.
Yeah, quite a roller coaster ride this year with the omega-3 fatty acid story. I mean, we all are familiar with the REDUCE-IT trial last year, which showed some positive results. And here in 2020, we had the STRENGTH trial. Now, this was a trial in statin-treated patients who were at high cardiovascular risk. They had high triglycerides and low HDLs, and they were treated with a combination of eicosapentaenoic acid, I'm going to call it EPA from here on, and docosahexaenoic acid, and I'm going to call that DHA. And the trial showed no reduction in MACE events, and that was obviously very different than what we saw in the REDUCE-IT study. People have really been scratching their heads. A lot of people pointed to differences in the placebo arms. In STRENGTH, they used corn oil as the placebo. In REDUCE-IT, they used mineral oil. And people were concerned that the mineral oil may have reduced the absorption of the statins and as a result, raised the LDL. And people thought, well, maybe that's the smoking gun. But Bob, if you look at another trial of VASCEPA, where the placebo was nothing, it was truly inert, there was nothing given, that's the JELIS trial. They saw in that study, without mineral oil, a 19% relative risk reduction. So that explanation does not really seem to hold water. The FDA, when they really did their deep dive, did not feel that that really held water. So we do have 2 positive trials I want to point out for VASCEPA. Now, here's what I think is really interesting. In REDUCE-IT, there was a relationship between higher levels of EPA and better outcomes. And they didn't see that relationship in STRENGTH. So, that's very, very interesting. And it makes you wonder, is there something going on in the STRENGTH trial where the benefits of EPA may have been offset? Again, One of the things that they did in strength was use DHA along with the EPA. And at this year's AHA meeting, there was some data showing that DHA may actually counter some of the benefits of EPA. In particular, the DHA was found to increase oxidized LDL. And we know that's the really bad LDL that may be associated with adverse outcomes. So a bit of a head scratcher there, Bob.
Yeah, no, Mike, I think you've summarized the state of the data pretty well. It certainly, when the presentation happened, a lot of back and forth between commentators and investigators. And I think you're getting to me at what's the essence of the issue, which is that we talk a lot about the class effects of things, but it really is important to look at the individual agents within a class because they are different molecular entities. They may not all work the same. And I think you're pointing out some of that. Are you using the drugs, Mike, in your patients with high triglycerides?
Well, I'm an interventional cardiologist, so I don't have a big clinical practice, but I am seeing it used more and more. I am seeing more and more patients on it.
Yeah, a lot of our preventive cardiology colleagues are beginning to use it to really try to drive down elevated triglycerides in patients who are otherwise well treated with statins, et cetera, who perhaps have already had an event, a coronary event, have diffuse atherosclerotic disease, and they're looking to continue to improve risk. So I think the story is going to still play itself out, but Reduce It looks like it's giving us some important information that we should be paying attention to. Let's switch a little bit, Mike, something you and I were talking about offline, which is the whole notion of statin myopathies. We've been using statins now, what, more than 30 years. And a clinical conundrum is still this group of patients who see you and tell you, doc, since I started the statin, my muscles hurt.
I didn't have muscle pain, but I tell you, I just started on simvastatin a few years back. And when I tried to get out of the car, I couldn't get out of the car and I had to lift myself out by my arms and I didn't know what was going on. And I got to thinking about it. I thought, well, maybe it's proximal muscle weakness from the statins in my legs. And I did stop it and it got better. And now I take a Torva 80 and I'm fine. So when I saw the Samson stuff, it really kind of blew my mind because I was personally convinced that, I was really developing a myopathy.
It really is interesting, isn't it? And I bet, Mike, did you check your CK at the time?
Well, I'm about the worst patient you can get. So I did.
So that's a resounding no. But yeah, I mean, I think we all see these patients who have some complaint of muscle weakness, muscle pain, most of the time without any evidence of elevated CK. And again, the same experience, Mike. You take some people off, the symptoms get better. You put them on another statin. Sometimes it's better, sometimes it's not. And you find yourself running through the whole gamut of statins. And particularly in the Samson trial, they actually compared it, against placebo, so an actual pill versus taking nothing.
Yeah.
And it looked as though there was something involved with the act of taking a pill. How did you interpret that?
Yeah, the placebo effect's powerful, but the nocebo effect also is powerful. And, it looks like there are some true cases of statin myopathy, but it seems to be the vast minority. Is that how you looked at it?
That was my takeaway. In fact, for me, this was the most cleverly designed trial of the AHA scientific sessions for me. I really, as you know, you and I both do a lot of large clinical trials. This was a well-designed, very small clinical trial, and kudos to the investigators for pulling it off. Doing a trial like this is not easy, Mike.
No, I agree.
Let's move over to an area you and I often spend a lot of our time thinking about together: antithrombotic therapy, antiplatelets, antithrombins. There has been a series of trials: trial in stable angina, trial of crushing the ADP inhibitors, twilight, TCOS, TAVR. You want to dive in?
You would think we would have moved beyond this field by now, but I was just dumbfounded how much activity there still is in the antiplatelet, antithrombin space. What's fascinating is now these drugs are coming off patent. Now you're starting to see some trials comparing them to each other. directly, where we hadn't had as much of that in the past. And one example is this Alpheus trial. You did the Plato study. You and your team showed that ticagrelor was superior to clopidogrel in the ACS setting. But what about stable angina? So they looked at 1,900 stable angina patients undergoing PCI, and they had to have one high-risk feature. Ticagrelor did what it always does. It improved platelet inhibition, but there was no difference in periprocedural MI or stent thrombosis. 1,900 patients, fair number of people. Now, there was no difference in major bleeds, but there were more of those less severe BARC1, BARC2 bleeds with ticagrelor. So an open label trial, people could be chronically on clopidogrel, but it looks like for stable angina patients, clopidogrel may be sufficient. What was your take?
Yeah, I think that to me, this gets into the whole notion of risk stratification, that clearly the group of patients who have an acute coronary event, we have data that more intensive platelet inhibition is better than less platelet intensive inhibition. But when you get into the stable angina realm, it might be that the risk is so attenuated anyways that going to a more potent drug, the trade-off of bleeding and ischemia may not be there. It seems that we can risk stratify appropriately and start to use the drugs that matter in a particular clinical setting. I think that's a good message.
Yeah. And, the other thing that surprises me is we never really latched on to the notion that platelets are really angry. I love it when I say angry platelets. They're really angry in the setting of ACS and activated, but they calm down over time. And they're more angry and activated than stable patients. You know what we never did, Bob, was we never matched the intensity of antiplatelets to the intensity of the anger of the platelets. And, we never really also did a nice job of stepping down to 60 of ticagrelor. Why get rid of it? Why not step down to 60? Why not go down to 5 of prasugrel? Why not go down to 50 of clopidogrel? We live in this binary world of stopping and starting, and you would have thought with all the discussion about tailoring therapy, we might do a little better, but we're still kind of in this on-off world.
Oh, I'm glad you're bringing that up, Mike. I've thought for a long time that one of the things we really ought to be doing in antithrombotic therapy is establishing the best regimen at certain periods of time in the cycle of the disease. And
Yep.
I think you've said it well. I mean, coronary disease, as you know, is a cycle. It's a chronic disease that's punctuated by acute events, and we've not necessarily looked at systematically. For example, Mike, I've wondered, are there periods in time where the antiplatelet effect is more important than the antithrombin effect and vice versa?
Yes.
The challenge is, as you say, these are hard trials to do generally. And then you start to top on it, put on top of it, all of the strategy type questions, and it becomes really unyielding. But I think now what we're seeing is clever investigators asking really clinically relevant questions for drugs that are largely off patent or going off patent. And so maybe it makes more sense at this period of time to do the strategy trials. You like nothing better than a good crushed pill.
Bob, you've seen the picture that Dwayne Pinto and I took of the clopidogrel pills in the esophagus or the stomach during the procedure.
I still use it in presentations.
Yeah, and people really said, that's just not true. That's not true. It is true. We actually filmed me with the pills on top of me and showed that they really are radio opaque. They have titanium in them or something, but it's a reminder that there is delayed absorption of these drugs. And one thing just for our audience, when I do this poll, 95% of docs out there, at least a while back, did not realize that if you give a opioid analgesic, the FDA label for all these drugs says, you know what, you should consider a parenteral drug because the absorption is so horrible. But to get around this, we've had a world where we crush ticagrelor, crush prasugrel. When I look up in the case, I see some poor soul sitting up there with a bunch of white stuff around their mouth. I'm not sure how much is going in or how much is around there on their lips. But we've tried this, and this crush trial, looked at crushing prasugrel versus regular good old prasugrel. This was not versus placebo. And it didn't improve ST resolution. It didn't get more arteries open in the setting of STEMI. I also want to remind the audience that these drugs really don't open up arteries. Remember back in Atlantic, giving ticagrelor upstream didn't open arteries or improve ST resolution in STEMI. In Clarity, we did not see that clopidogrel opened up arteries. These drugs do a good job of preventing rethrombosis, stent thrombosis, reocclusion, but they're not going to get arteries open. It's in distinction to another class of drugs, the good old 2B3 inhibitors, which do get arteries open. And, we're now going to see some upstream approaches with some sub-Q 2B3 inhibitors to try and get things open more quickly. But just in terms of the mechanism of action, it just doesn't seem like the thienopyridines are going to do the trick in patency.
Well, it's interesting, isn't it? The whole concept of crush. I mean, you and I have been involved in the Cangrelor trials, a short-acting IV ADP inhibitor. And it's not made sense to me that, well, why would you go through all this crush, series of maneuvers when there's a short-acting IV drug available if you really believe that you need to get the drug on fast? And all of the data from the Champion trials that you and I are involved with really do show that a rapidly acting ADP inhibitor is a pretty good idea.
Yeah. Yeah, I agree, Bob. It's, also we should point out this year, the ESC changed the guidelines to make upstream thienopyridine therapy a class 3 contraindication if you have non-SD ACS and if you're going to the lab quickly or if you don't know the anatomy. So an important change in the guidelines out there as well.
Yeah, and for me, what that has told me is that, okay, once you know the anatomy and you've decided, for example, that you're going to do intervention or not, and you might want to start an ADP inhibitor, if you're going to do your procedure right away, I mean, the data from Champion Phoenix is pretty compelling. Get the rapidly acting ADP inhibitor on board at that time. But certainly waiting until you see the anatomy and then having a drug rapidly available seems to make good sense.
Yes. And there are going to be some drugs coming down the pike that will reverse some of these drugs, like ticagrelor.
Well, let's talk about ticagrelor. A couple of trials, Twilight and TICOS.
Yeah.
Do you want to put them both together and maybe give us your bottom line?
The bottom line is in Twilight, we showed that if you give 3 months of DAPT and then randomize people to ticagrelor monotherapy after that versus keeping DAPT going, there was less bleeding with the TICAG monotherapy and no increase in ischemic events. Now, we didn't include STEMI patients in that study, and the TICO STEMI study was a subgroup analysis from the overall TICO trial. 1,100 STEMI patients, threefold reduction in bleeding from 2.9% down to 0.9% if you just give ticagrelor monotherapy after 3 months instead of giving DAPT. And no difference in MACE, 2.7 versus 2.5%. So really does confirm the results of Twilight. Aspirin isn't a great antiplatelet. It's not as good as the thienopyridines in terms of its potency, and it does cause gastric erosion. So I think we're seeing less is more when it comes to aspirin.
Yeah, it's interesting, isn't it, Mike? When we were doing this show in years past, and not that many years past, it was that aspirin was sort of that foundational pillar that you couldn't move. And I think a whole series of trials now have raised questions about that. And I think you're right that, even if we think about the AF trials with triple therapy, getting rid of the aspirin in many cases looks to be a good idea, doesn't it?
Oh, I think, yeah, the data really is really firmed up now with thousands and thousands of patients that dual therapy with a thienopyridine and a NOAC is probably the way to go, and getting rid of aspirin is the way to go there. What's fascinating to me philosophically, Bob, is that what we did is we just kept adding on top of aspirin. We never replaced aspirin. And so, what we did is we said, well, we got aspirin. Does this drug add anything to aspirin? Here's what we never did. We never said, well, we got this new better drug. Does aspirin add anything to it? We never did that.
Remember, worse was dropping the
Yeah,
aspirin. As opposed to,
exactly. So it
you know,
wasn't until a few years ago, we did this for 20 years where we just kept piling things on.
yeah. Well, Mike, speaking of areas of aspirin, let's talk about TAVI, which was an interesting study, moving out of the coronaries into the valve range realm, but an interesting trial.
Yeah. There's this popular TAVI study, two parts of it. One was called the B cohort, and these were people on chronic oral anticoagulation. And of course, if you got rid of the clopidogrel, you reduced bleeding by 41%, and you didn't increase your thrombotic events. I think people were a little astonished by the safety of no thrombotic events. What we saw this year was if you're not on anticoagulants, what do you need to do? And they compared aspirin alone versus DAPT with clopidogrel for 3 months in 690 people. Keep in mind, these are old people. These are 80-year-olds. And the bleeding went down, as you would expect, from 26.6% down to 15% with aspirin alone. And no difference in ischemic outcomes, 9.9% versus 9.7. So less is more. Less is more once again.
Yeah, good description of that particular trial, and I think an important clinically valuable set of information. Mike, I want to close with probably the area that's had the most action, if you will, this year, which is heart failure. We've got the SGL2 inhibitors, we've got the guanine cyclase inhibitors, we've got the the muscly active drugs, omecamtiv, Emperor Reduced, Victoria, and Galactic. Again, you want to give us the gestalt, Mike. How does this fit into the paradigm of caring for the heart failure patient?
Well, I think this has probably been one of the biggest 2 years, I would say, for heart failure. I mean, we haven't had a lot of improvements focusing on LV contractility. I mean, things like milrinone increased mortality. But Bob, you highlighted a few new pathways targeting the myocardium. The old way was the classic calcitropes. Those had deleterious effects. The newer class is what we're calling mitotropes, improving the energetics of the heart, like perhexylene and ranolazine. And as you mentioned, one of the leading theories about the SGLT2 inhibitors is they're improving energetics. And now a new third class of myotropes, where the drugs are acting on the sarcomere. We had DAPA, which showed it improved outcomes. Now this year we had Emperor Reduced, also another SGLT2 inhibitor in over 7,000 patients, also showing improved outcomes. DAPA had a reduction in death where we didn't see that with EMPA, although it was a smaller trial with EMPA. The concordance, though, for this class of drugs really starts to suggest that this should be part of the foundational therapy, the SGLT2s. And then there was a new kid on the block. I studied in Soloist, sotagliflozin, and it got stopped early, the trial of this other SGLT1 and 2 inhibitor, and it too reduced death and recurrent hospitalization. So we got 3 good shots on goal that it worked with this class of drugs. So it looks like this is really a good new foundational therapy. You mentioned another approach, the SGC stimulators like vericiguat, which directly enhances cyclic GMP. The Victoria trial looked at this drug. Again, reduced cardiovascular death or first hospitalization by 10%. No difference in death. And then finally, the last one that you mentioned, the new myotrope, omecamtiv. It makes it easier for the myosin to pull on the actin as a rope. Didn't increase oxygen demand, didn't increase calcium influx, prolongs ejection time, increased stroke volume, does good things in terms of the mechanics. And like the other drugs, also reduced, death or hospitalization or urgent visit. No benefit, though, in mortality. So, Bob, all of them look to reduce death and hospitalization, all these new drugs. Really, DAPA is kind of standing out, though, as the one that reduced mortality.
Yeah, it really is the case that the SGL2 inhibitors, isn't it, are going to really look to be truly foundational because of the very hard clinical endpoint benefit, and that some of the other drugs look like they may have a niche effect on top of what will now be multi-drug therapy with sabicutrol, valsartan, beta blockers, mineralocorticoid receptor antagonism, SGL2 inhibition. I mean, it really is very aggressive foundational therapy that makes the difference. And I look forward to seeing the next version of the heart failure guidelines to see how our colleagues in that world sort all of this out. What drugs, what patients, when.
That sounds more like a meal plan than anything, right? I mean, it's a lot of drugs to take, but
It's a lot of drugs. I mean, and we got to think of, a lot of them are, or some of them are generically available, but not all. And we're going to have to think about that from a societal cost effectiveness prevention. But if you start reducing hospitalization in particular, you do save money, don't you?
you do. And it really is a testament to all the different pathways the body has to compensate for things. And you have to block all these compensatory pathways to make an impact. So life is multivariate and biology is multi-targets.
Agreed, and kudos to our colleagues in the heart failure world
Yeah.
for really leading some fantastic trials. Well, Mike, as always, this exercise of thinking about the year has been fun with you. I think it's also been incredibly impressive that the science continues despite all the challenges with COVID that we're dealing with. And you and I are going to have another session where we talk about the COVID related lessons for cardiologists. But you want to try to put some context, Mike, about the science going on while COVID is affecting us in so many different ways?
Yeah, it really amazes me. I mean, we have been able to continue to do trials in the midst of all this, and it's a real credit to the investigators. I have to also say, though, sadly, we lost 2 out of 50 country leaders in one of our trials. One of them, Tony Gershlik, recently died due to COVID. So we've had some hits. We've also had sites closed down permanently as a result of COVID. But despite that, the science has continued in the cardiovascular space. It slowed down, when we had the shutdown, but now we're just going to keep going and just plugging away. It's a real testament to the docs, the nurses, and most importantly, the patients for agreeing to participate.
Well, I want to thank you, Mike, for joining us. This has been a terrific review of 2020 and what's gone on in cardiovascular science and medicine. My guest has been Dr. Mike Gibson from the Beth Israel Deaconess Medical Center in Boston, where he's an interventional cardiologist, the Harvard Medical School, where he's a professor of medicine, and the BAME Institute, where he is the director and CEO of that academic research organization. Thanks, Mike, for joining us on Medscape Cardiology.
Thanks, Bob.